Sean, can we start?
Yeah. Please start.
Okay. So good evening, friends. I'm Dr. Ramesh. I'm the Chief of Critical Care Continental Hospital. On behalf of Continental Critical Care team, I would like to welcome you for this online webinar session on green ICU and environmental sustainability in ICU. So why we need to know about this topic? So as we all know, global gas emission has led to as a major impact on extreme weather changes, extreme temperature changes, and also increase in the vector-borne diseases and infectious complications related to that. So the burden, if you ask me, how is the burden? In a study, it was shown that 7 to 10% of the carbon dioxide emission is from the healthcare system. It can be from the hospital, different areas of the hospital, like ICU, operation theater, laboratory, or the areas where the consumables and the pharmacy drugs are produced, like the industries. So in 2023 survey, India is contributing almost 2.2 metric tons of carbon dioxide in 2023. And when it comes to ICU being an energy intensive area of the hospital, the energy consumption of the in ICU is more compared to other areas. Like we will be using for ventilators, various instruments like monitors, infusion pumps, renal replacement therapies, and the consumables what we use day in and day out, like gloves, starting from gloves, and the infusion sets and all, and the drugs what we use and the lab tests what we advise, all will contribute to the carbon footprints. So when our target is to reduce the carbon gas emission to 80 to 90% by 2050. In India, it is 2070. So it becomes our responsibility as a healthcare provider, healthcare physician, to reduce our contribution to the gas emission in various levels with a strategic plan. So government already has various plans like Swachh Bharat scheme, National Action Plan for climate change, solar missions, and FAME India programs like electrical vehicles. So plastic disposable rules and regulations. So with this, government is already addressing this issue, and it becomes our obligation as a healthcare provider to address this issue and take action at each level with a strategic plan. To know more about this topic, we have our eminent speakers, Dr. Faisal Masud and Dr. S. Javeri. So we welcome you, sir.
Thank you. Thank you,
Good
Dr.
morning. And good morning from my side. And I think good evening your side, Dr. Mesh. Thank you for the introduction.
Thank you,
So,
Dr. Ramesh.
Dr. Faisal Masud, sir, is the chair in anesthesia and critical care, medical director, Center of Critical Care at Houston Methodist Hospital. Sir has received various awards like Presidential Gold Medal and Gold Apple Award for Excellence in Teaching 4 times almost. Sir has published many articles on green ICU and environmental sustainability, and he has many initiatives on green ICUs, and which was taken as it was national's first collaborative and systematic approach for green ICU in US. Welcome you, sir.
Thank you, Dr. Mesh.
Yeah. Our second speaker, Dr. S. Javeri, sir is the Director of Critical Care and Emergency Medicine, Regency Super Specialty Hospital, Lucknow. Sir has published around 65 articles, and he is the current Secretary of Society of Neurocritical Care. Sir has received a Presidential Award, Citation Award also. Welcome you, sir.
Thank you, Dr. Ramesh, and thanks for organizing such a wonderful program.
Thank you, sir. So without wasting much time, we'll go on to our session. So I request audience to write down your questions in the chat box so that it will be taken at the end of the session. So over to you, sir, Dr. Faisal, sir.
Well, thank you, Dr. Mesh and Dr. Veri. It's a pleasure meeting you. It's a journey. Mark, I'm going to request you to kind of show the slide, the first to the screen. So while Marco is going to show that, it's very important to know why it's very important, why we're doing it, why we are doing this. And Dr. Mish very nicely articulated, some of the salient facts. I can only share my personal journey. I'm a grandfather. And to me, I didn't really pay too much attention to it, until a few years ago. But I could see that, the climate impact in all communities all across the world were being an impact. And what we were also seeing was that, yeah, this is getting more and more worse in every part of the world. I mean, they keep on talking about worse heat or worse tornado or worse flooding or thing wise. So something is changing. I don't know all the answers. I have no idea, but I felt that for my children and for my grandchildren, we got to do something different. I don't know what all the answers are, but we got to do something different. We can't just take as it is. And of all of that, in healthcare, as doctors, nurses, and other thing wise, the first thing we focus on is do no harm. The first thing we focus on our patients and the community that we serve. So our community is getting harmed. It is impersonal to all the doctors to us. And the analogy I can give you is that, for 50 plus years, we've been talking and doctors have been in the forefront about don't smoke. It causes your lung. It's a smoke environment and you can have primary smoke damage or secondary smokers. So we really said that this is not helping, even though we were not selling tobacco, we were not buying tobacco, we were not, but our patients were getting harmed. So we took a lead on it. So, and I'll share with you later on how all of these things are impacting the patient that we serve, the communities where we serve. So it's personal, and it is also what we all think of how we need to be practicing medicine. Now, this is a relatively new topic, a new things about in critical care, but it is something which we feel can really make a difference on. So that's why I chose this header for my talk is the future of ICU green. And I hope that end of my discussion and my presentation, you may want to think differently and you may want to question and kind of do something wise. So I look forward to question and answer. I do know that Dr. Juveri is a much better speaker than I am. So I'm just like, when the big star comes in, the small person comes in the intro. I'm the intro guy, he's the star. So I'm just going to briefly, I'm going to lay the foundation for him to be the thing by. So, all right. Okay. So sorry, I took a long time, but I just want to give you, to me, these things are personal. So can you go to the next slide, please? So I want to give a little bit insight where do I practice. So I have a blessing to be the medical director for Center for Critical Care. We are in Houston. We have approximately in our ICU and IMU, we have 29,000 patients go through our ICU IMU every year. And every fifth patient admitted to our hospital system comes to an ICU IMU. It is that we have got about 8 locations. We have a 350 ICU beds, but if you include intermediate care unit or step down unit or high dependency unit, depending on the country you're practicing, about 500, 70 plus critical care specialists, 125 advanced protectors, more than 1,000 nurses, 250 trainers, and all the stuff. So the reason this is important is that, when I started my journey 3 years ago, and I was talking to my colleagues, who really have led this in the country, in the world, is really our colleagues in Australia and New Zealand. Hats off to them. And I was talking to my colleague in New Zealand, and she asked me, Faisal, how many beds do you have in your hospital system? So I said, we have got 350 beds in our hospital system. So she paused. In the whole country of New Zealand, there are only 290 ICU beds. What that means is they can do everything, but if we don't do something, it will not change. I'll apologize up front. I've got a lot of allergies, so my voice may sometimes become raspy, but I'll keep on drinking water. Marco, next one, please. Next slide, please. This is the latest. So in 2094, the global temperature was 2.32, above the 20th century. This is the highest recorded global temperature since 1850. And if you look at this is a global map, not a USA, not a Europe, not Asia, globally. Look at the hot sun, record heat. This is not trivial. These are facts. And what I would like to base my conversation is on facts. We all have opinions. We may think that way, but we have to kind of stick with some facts because facts, it's kind of hard to fight against. So this is real fact. So this was the hottest recorded since 1850, and globally it is impacting some a lot more and some are not as much. Next slide. This is a snapshot of the climate anomalies. Again, the word anomaly is not, that means it is not expected. And if you look at this map, it is a global map. And it also shows that the impact of heat, flooding, and everything is impacting weather. More hurricanes, more seasonal impact on Arctic or Persian Gulf or North Indian cyclones or South Indian on a typhoon. This is not my problem or your problem. It is our problem. It is impacting all of us. And some of them a lot more, some of them a lot less. Some countries and societies may be better equipped to deal with it, some may not be. But at the end of the day, we are all human. We all have patience, no matter what you do. So this is really, again, facts. So I kind of like to say, so this is just to give you an idea that this is equal opportunity impacting. It's not anything. Next slide. One example. The Europe's drought crisis could be the worst in 500 years. And if you remember plague, if you remember all of this thing wise, historically, this is not trivial. So if they have drought, this is a worldwide implications for everybody, whether they drought in a bigger continent. This Europe is really as a continent. This will give you an example. Unfortunately, Africa and other people have experienced drought. This seems to be, again, as said, more anomalies taking place more frequently, more commonly, more widespread. Next slide. 90% of the orally administered pharmaceutical are excreted in the wastewater as the active substances in feces and urine patient. That's huge. That means we think that, okay, I took a tablet, okay, end of discussion. But those chemicals are not disappearing, whether those chemicals are part of the pharmaceutical or preservatives or anything, they're coming in and they're going in our water, in our supplies and everything. So this is washing up everywhere. So the levels are increasing and increasing. So this is important to know. I did not know that until we start looking into it. So I just want to kind of make you aware of that. Next slide. In US healthcare, they do a lot of studies. So disease burden from the healthcare pollution is in the same order of magnitude of death from medical error. That means they can't calculate what potential harm can be from medical error related, and this is hundreds and 100,000 plus. And they felt that this is scope. So there's a lot of talk all across the US. Hey, we have to be very mindful. We have to prevent patient safety, patient harm, institutional healthcare improvement, national and everything. So this is impacting, but the climate impact on our fellow US is also, and I would not be shocked if similar impact is not happening in many other countries. It's whether they are measuring that or not. And I think some of the countries and areas that are started to measure, and I'll share some data from India also, what they're also start to measure, just to highlight where we are. Next slide. The global medical plastic, and again, not every plastic, but global medical plastic accounts for about 2% total market by value and is growing increasingly. US consume 40% of medical devices, so we have a lot more burden. So US, we have a lot more burden today, but the plastic is going somewhere. Unfortunately, a lot of this recycling and all the stuff, it is not properly done or get dumped and not done and shipped, it happens to middle income and lower income countries. And that is, in fact, this is really a snapshot how all of those things in. And again, more and more thing. Part of the thing is that we are providing care to people who are living longer and longer and more intervention. So, people who used to average age was, let's say, 50, 60, and now 80, 70 is a new norm. That means they're needing more healthcare. That means don't lie. So just to give you a little bit of insight of that. Next slide. So this is a very, very important slide. And the reason it is that this really highlights how climate change impact related health of people and the hospital system as well. So let's talk about the first about health. Heat related illness, heat stroke, heat compromise, heat related, ability to go out, do exercise, do thing wise, when everything get impacted. It's when they have thunderstorms, when they have hurricanes, when they have fires, they get, people have to relocate, you have to move out, do all of the stuff wise. Lung disease is such a common, and I know that I'm originally from Pakistan, and Lahore and Karachi and Delhi pollution is really impacted. You can't see the sky. And ironically, in COVID, those areas, they could see the sky and see the mountains, because the human activity does. So it is impacting these people. We need to ask people who have got allergies and things how their life is getting compromised. And I give the analogy of smoking. The smoking affects lungs. It is really also lung infections. The number of kind of infection, the vectors are growing and growing. It is expanding. When you have heat related issue and climate issue, whether it's flooding, it's hurricanes, it's crops and everything, and those people don't have the way to earn, it affects the poor more or the disadvantaged more. The people who are younger, the young kids, the elderly, the people who are not financially stable, they don't get to it. So it's direct impact on their malnutrition. These lead to conflict and migration. So it's health on so many levels. So how does it affect the health system? When people are more sick, more complicated, they come more to the hospital and utilize more resources. They're more decline in quality. We are part of the same society. So whatever is affecting society affects the doctors, nurses, and everything wise. So health-related risk, damage to infrastructure, supply chain damage, flooding, and everything. When the hospital get compromised, the clinic gets run over. Guess what? So social and structural determinants of health, whether housing damage, livelihood, reduce, and all the stuff, these are all system. And again, at the bottom is the ecological impact wise. So this, if you go look at it, every aspect that we do, you and I today, is getting impacted. I thought that this is a very good infographic to at least bring the table because this is a good way to have a dialogue about it. Thank you. Next slide. So what happens to the downstream plastic? 99% plastics are made from fossil fuels. It completes to the climate change. Only 9% of plastic ever get pledged. Not only health related, but overall. 8 to 11 million tons enter the ocean annually. And this gives you the graph of where the countries and areas are putting into where the plastic get done, not get done, goes to the landfill, incinerated or recycled. And as you can see, it's all over, but majority is not getting recycled. So this gives you a snapshot. And I'll tell you in the next slides why this is impacting us on a daily basis. So as you can see, it is important to be mindful of that. Next slide. This is why. This is a very nicely recently published study in which the pollutants in atherosclerotic plaques and cardiovascular events. So there's a very nice study and there's a very good work which is carved out, and they start measuring plastic in human body. And previously we did not know because it was such a micro. So what happens in plastic, it decreases in size, it doesn't disappear. So when they start looking at microns and brains and everything, they found out that a lot of plastics are accumulating in the human body. And this is the first study that at least very, very good job of looking at it. Oh, where is this plastic going? We're absorbing. Most commonly, it is coming from our eating, whether it's from whatever source we're getting. And this is impacting in our plaques, in atherosclerotic plaques, and all of these things. So it is impacting directly. So if we think the plastic is a problem, not my problem, it is becoming my problem. It is becoming your problem. It is becoming our problem. This is one of fantastic evidence, and it was just recently published, and so I thought I'll share with you. And this is a very beautiful infographic, made it simplified, how plastic is accumulating and like and causing anything wise. So this is not trivial. This is happening as we speak, and more is happening. Next slide. This is an impact. So when hurricanes happen, and this is natural of of when flooding happened, guess what? We don't have clinics. We don't have an emergency room. We don't have OR. We don't have operation theater or hospital. This is just a snapshot. And especially when they were damaged to hurricane in the US, we ran out of fluids. So this is how will we provide healthcare? How will we see our patients? How will patients come to? Where will they go? Where will they go? If they're not getting their blood pressure medication, if they can't get their dialysis, if they're sick, they can't go, they're going to be impacted, whether they're going to have worse health or they may not even make it. So this is impacting to our institution. And I can take this snapshot of pictures from US to give it to any country, and I will not be surprised to do that. Next slide. So how's getting impacted? There's a lot of, as Dr. Ramesh mentioned, excellent work being done in India, but it is getting impacted. India was ranked 7th among the list of countries most impacted. India is one of the 1/5 of humanity. You all are getting the most impacted in India. Extremely hot days, more than 35, are expected to increase from approximately 5 per year in 2010 to 42. This is already happening. As a result, the death rate due to climate change is projected to increase by 10%, equivalent to 60 deaths per 100,000, but 1.5 million additional deaths will take place in India alone. So this is not my opinion. These are facts that are coming from. 1.6 million deaths were attributed to air pollution in 2019 in India alone, contributed to a higher increase. And by 2060, 2,000 deaths will be caused by air pollution per year per million patients compared to 508. So fourfold difference from 2010 to the invoice. So this is real fact. So this is what is happening to mortality rate. Seventh most impacted, because India is not a small country. 7th most impacted, that means hundreds and millions of people are getting impacted. Invoice. Next slide. Heat mortality, this is some of the data showed from 1960 to 2009. Heat mortality by 146%. And against in mortality, if things don't change, if the pollution impact, you can have the worst case scenario minimal. You can have a huge impact or medium impact. And this is the impact of percentage changes, which is share of mortality. So again, very published. Another global survey was that 1 in 5% think that climate change has impacted themselves and their life and everything wise. So mostly people know this is happening. They just don't know why it is happening and how is it happening or what can I do about it. But 1/5 of humanity already is worried about it. Hey, something's happening because it's not trivial. I can tell you when we had hurricane, well, in our Houston, no electricity for 12 days, I didn't have anything. I had to shift my family because it was very hot. When there was, and can you imagine, Houston is a very cold place. Guess what? Last year we had snow. We had snow, and we are not used to snow. So everything got shut down. so snow in Houston is not a routine thing. That's weird. So we had snow for a few days. So I'm just giving an example. So this is not happening in India alone. So the N1/5 of it. And the reason part thing is, I'm gonna wake you why it is important. Next slide. So why are we doing this? And why are centers? So I talked about patient communities. At the end of the day, it's really about the patient that we serve in the community. So we have to focus on why we're doing this. Another thing is, at least in the part of the world, in most of the world, that we see the biggest workforce in intensive care unit are nurses, the largest. Doctors are there, but ratio is very different. Most of the nurses are young youth in 20s and 30s. To them, this is real. To them, this is important. I'm the old generation. I'm the guy who messed up everything, who made everything polluted and everything. So I'm the bad guy as far as I'm concerned. So they think, another thing we realize that there's not much innovation research done at it. We have not looked at all the solution. We have not looked quantified. Another thing which was surprising was, and I'll share with you, it's a huge financial dividend. We're saving a lot of money for our institution or our healthcare because somebody's paying for that. And I'll share with you some of the example. We feel if we do all those 4 things, we will automatically have an environmental. I don't want to get stuck into political battles or fights or thing-wise. I want to focus on my patients and community that we serve. We feel if we do the top 4 things, it will automatically have an economic. So we're not saying about green flags and all this stuff. We don't want to do that because that can be distracted. The people like to put you in compartments. We serve here for our patients. That's where we look at it. So I think that is hard to push back against versus anything wise. So let's go next slide. So when we started this journey 3 years, we said, well, and I talked around my own team, my hospital, well, nobody knew. We had no awareness, no plans, no engagement, no measurement, no accountability. It was as if we were jumping out of the plane. Hey, well, I don't know where we land or not, so we're nothing. So I said, we got to do something. And I was sharing with Dr. Ramesh earlier on that when we started to look at it in a couple of years ago, I looked at what's happening in the US, so I saw that a lot of work, excellent work being done in New Zealand and Australia. Perhaps they felt they were more a threat. And then Europe, but there's nothing really. And I could only find one paper which actually quantified the amount of waste in an ICU. So at least ICUs were not engaged. So we said, okay, well, we gotta do something different. Okay, so I'm just sharing you how our journey started. It's very important to know that because everybody's in a different aspect of journey. Somebody started the journey, somebody middle. I don't think so any one of us is close to Venu. I think we have a long journey. And I tell my junior faculty that this is at least a quarter century journey. This is not gonna get fixed in 1 day, 2 day, and all this stuff. Next slide. We are physicians, we're scientists, we love emotions, but we always believe in science. So where is the evidence? In God we trust, all others may bring data. I love this thing because data is data. And as an example is that data it takes opinion out, it keeps the fact in. So where is the evidence? Okay, next slide. So scope, and let me give you a little bit of education. So how people measure greenhouse impact, they categorize in scope 1, scope 2, scope 3. Okay, what does that mean? Scope 1 is what all the things which come to the scope directly coming from the fossil fuel, from the cars, from all the anesthetic gases which are being manufactured and all this coming. Scope 2 is the energy from the hospital, campus, and or the infrastructure. Okay, that means that what is being the building, the electric wise, someone who's turning on the lights on, who's running the AC, who's running thing on. That's a huge impact. These bars are not meant to describe the proportional impact. Scope 2 is huge. So if the source where the electricity comes to your hospital, water, so all of those things are important. The reason we expanded the scope 3, this is published from my college in Tanya, is what we can do. I'm not the one who is designing or giving permit to the building. So I can't say that go change the building. Okay, there are other smarter people to do that. But I always want to look at what I can do. I don't focus on what everybody else should always be doing, but I want to focus what I say that we as healthcare can do. And this is talk about green and sustainable ICU. We want to look at what we can do in the critical care environment. As you know, so how much water we use, what drugs we use. And let me give an example. We know that intravenous medications have a bigger carbon footprint than pure medication. Do we need all these different medication? How much are we wasting? Do we need what is high quality care or low value care? What devices we need? And let me tell you, and very fundamental thing, when I started this initiative in our hospital system, we in our teams, and I'll elaborate more, we made sure that we will have quality department along with us and infection control. Our commitment to our patient was that we will never compromise the quality of care we do in order to do this thing wise. That is very fundamental. I never want a patient to or family say, we are providing a cheap or low quality care because of environment or anything. Never. So I just want to give you a little bit of fundamental. Test, and I will share some of the data is how many tests do we need? And there's a different carbon footprint, MRI, CAT scan thing, X-ray, food services, hospital staff, commuting, medical device. So just give a little bit of insight. And the patient family when they come up. So just give a little bit of insight how they get measured and all the stuff wise. And at the ICU level wise, hospital level wise. So this is what we can potentially make an impact. Next slide. This is an impact. There is, I think, one more good paper which also quantifies per day impact. So and again, just to give you, this is from a European country, and this does not always equal to every country's ICU. But somebody had to measure, somebody had to do it, take a leap of faith. So just to have a disclaimer on that. So amount of mass, it produces 17 kilogram mass, 12 kilograms is CO2 emission, and LAMP for impact of about 4 I would say I'm kind of moving 4 meters square and 300 liters of water used. And again, because remember the reason we're using much more European data and US data, because we contribute a lot more to the environment as far as greenhouse back than some of the other countries in the world. So we have a much more responsibility. So I'm just sharing it with you. So this will give you, people have quantified how much we do per patient per day. So this is not trivial, and this leads to greenhouse impact wise. So if I have 350 ICU beds, this is 350 times 12. And I don't know, I'm not good in math. That's why I became a doctor, so you can just multiply yourself and see how much carbon emission we're doing. So that's why it's important. Next slide. This is again coming from the North American and European data. This is the number of gloves, disposable gloves, which are used. So let me give you an example. If the patient is in the ICU, how many times the nurse is putting on gloves? How many times the consultant, the house staff, the resident staff, the registrar, the visitors, the person drawing labs is doing all this stuff. How many other compressible or liquid medicines, how many syringes, because ICU we do a lot of, we are ventilators, we are thing-wise, so this is not trivial-wise, and I'll show you how many tubes. So this is really quantifying a thing-wise. Now, this may number be very different from you, but I would encourage you to just quantify. You'll be surprised and shocked. When we start quantifying, we were shocked. We thought, oh, no big deal. And again, not all ICU across the world use equally. So I would encourage you to quantify your level, but this gives you a little bit of impact-wise. Next slide. So why is it important to us? In healthcare contributes about 5% of worldwide greenhouse impact. In the US, the carbon footprint of the healthcare system is 10%. So 10% is coming from us. That's a big number. Many lives are impacted. Within the healthcare system, ICUs contribute 3 times more than the regular flow because A, these are sick patients, they need more resources, they need more medication, they need more support, they need much more. So that's natural. Estimate a carbon footprint in a US hospital showed this much per day and correspond to emission car driven about 500,000 kilometers. So let's say if I have 1,000 kilometers, 350, so 350,000 kilometers of car driven per day in my hospital system alone. And with 100,000 ICU beds in the country, 100 million kilometers driven per year alone. So we cannot say that we have nothing to do. And this is just ICU alone. I'm not talking about the whole hospital. Just to give you a little insight. So look at your own data. I think it'll be good for. Next slide. This is another thing which is what we is actually the products that we get. How much is actually the product and how much is the packaging? Whether it's stitch cutter, tissue, cloths. And again, with critical care people, I can't tell you about your central line kits that you guys. We've got central line kits. So much stuff is in there we don't necessarily use. They have got this printer, paperwork. And how many times people read those things? They get thrown out. We do all these things. So this is just very quantifiable that how much is actually the thing with you and how much is a like these compressors, huge. Most of his packaging. Disposal, look at most of his packaging. These syringes, most of his packaging, very little. So that means we need to challenge the industry to decrease the packaging because that gets thrown out. Or we have to kind of be more mindful of how we can minimize that. So this is very good data to know that. Next slide. So with that in mind, we said we got to do something. So we looked at our hospital system. This is the QR code is for you to scan and read the publication. This is the first one in the US, which really kind of look at it, what is happening, what do we need to keep on doing, and how the future holds, and how do we start quantifying. So I think this will give an insight, at least from US perspective wise, because again, we feel we had a huge impact. We got to do this thing. So we actually have a second paper in the making as to what we have done so far and kind of quantifying that was. So this was our framework. This was some of the initial work, but a second paper will be coming. We'll tell you where we are on the journey and how we're doing it also. And the QR code is available. Next slide. This is a proposed pathway. Infrastructure, first of all, life cycle assessment, very difficult to do because a lot of people don't measure. So we're still working with our partners, but this is work intra-organization, and I think working with industry also how to do that. Process, so create green ICU team. This is very important, and we've done that across system. We have a team, which is team recycle, team reduce, team rethink. So different teams, rethink. Let's do the thing differently. Let's do recycle. Team reduce. And then create synergy and implementing across the system wide, and then start measuring, and goal setting, short term, long term. So we felt that this is from support structure, processes, implementation, engagement, and everything. So you got to engage inside the hospital, outside the hospital, internal. So we feel that's Zora, and we'll share some of the things which we've done so far already. Again, a QR code. Next slide. So measurement, collaborate. We were fortunate that at the same time we were interested, our hospital created an office of sustainability. And we didn't even know they were creating it. And said, oh my God, we have one. So we start partnering with them, setting scope, project support. We're looking at life cycle assessment. There's a very good software which is coming in now, by the way, which is helping us to quantify and used to measure scale wise. We're also a huge engagement of pharmacy, because pharmaceutical contribute a huge component of it. Because otherwise, and we got certain wise. So we got some of these measurements. We'll share some of them. Next slide. So measurement is about, this is from our academic medicine center. Our sustainability office measured what is for our campus. Scope 1, Scope 2 from the building and everything is metric ton. Scope 3 is what you do clinically. So we are creating the footprint which is equal to Walmart, which is the biggest employer in the world from people wise. Next slide. What does all these numbers mean? So this is the metric ton, Scope 3 emissions, impact wise, and we will start to benchmarking next from Kaiser Permanente, which is a large hospital system, and employer like Walmart. So our carbon footprint per FTE or employee is a lot higher than a lot of the employers and anything wise. So that means we got to do something different. Next slide. So what does that mean? Emissions. It means that per year, 18 million translates to 18 million gallons of gas, 183 million pounds of coal, 386,530 barrels of oil. And this is yearly household energy, 21,000 homes. So what we are using to compound a hospital, this is what it means equivalent. I think this is important because sometimes this number of metric ton, we don't know what it means. Who cares? 166. This is real. This is what it translates to, so people can relate to it. Next slide. So what we did we start to do a lot of internal engagement, because we have to first, hey, are we crazy? We engage our hospitals and our own leadership, our office of sustainability. Then we start to reach out. As you mentioned, we reach out. We're working and collaborate with ANZAC, Australia and New Zealand, with Texas A&M University, with the business team-wise, European side internal medicine. Medline is our huge people who can help us to recycle, repurpose. The University of Brighton, we're working with UK, with Heather Bade and a society. Prairie and View, and now we have a partnership and relationship with Practice Green Health, Healthcare Without Harm, and we're ever expanding, because we feel that we got to learn together, share together, internal action, because it's not our own. We are not in isolation. We're everybody in the same boat. Next slide. This is a very important step for you to kind of move forward. So with that, we worked with our Society of Medicine. Our team member, 2 key members were part of this task force. This QR code is available. You can download it. This was the first task force paper came out in February of this year. This is a lot based on a lot of what we were doing and other people are doing. And we, so I'm happy that our society finally took this to ThinkWise, and this is very important. So it's there for you to take a QR code. Next slide. We had multiple ICU meetings, everything. We presented to our executive leadership, a medical leadership, and I'll tell you what we used to approach. We presented to our board of the hospital system. We create a concept of fear of missing out. You'll be amazed that if I'm doing a successful, people want to do that also, because, hey, I'm going to left out. I'm going to want to do that also. So we create this mindset, hey, we created a buzz about it, excitement about it. So really about it is to do the thing, to think out of the box, and people came fantastic ideas. And the guy was, this is not added work, this is exciting. And we're also giving award with money, gave ICU some award money, recognition. What that does, it creates an excitement, because it's not the only thing. This is not another task, another workload, another mandate. This is, I tell you, 90% of these projects and initiatives came from the local team. I had no idea. They say, hey, we got to do this thing. And they take on it. It's amazing. FOMO is very important. Next slide. So these are an example, some of our ICUs, projects, different projects. We didn't tell them. They looked at every single thing. They looked at system-wide, hospital-wise, some of the key leaders. This is just a snapshot. They create green teams. I did not force anybody. They came up with their own team member. They came up with their own shit. Because if you create that excitement, you make the case of why, they are very smart people. They want to do that. So this is an example. Next slide. So again, team reduce. Recyclable material. This is placing more recyclable bins. Conduct workshop and education. PVC recycling from tubings, from packets, reprocessing a lot of things. ISQ, different projects. This is team reduce. So remember, I talked to you about prior green teams, team reduce, or all of this thing. Right? So I'm not going to go step by step, but again, this is just to go to show how this. Or if you do less X-rays, if you do less of thing wise, we wean the patient off the oxygen quickly. You're going to get them out of the ICU quickly. You may not even need the oxygen. You get them out of the hospital. So direct impact on length of stay. So reduce. Why do we need? What happens is we're comfortable with 6 liters of oxygen. We don't actively move that. It should change. Steam reduce. And again, guys, next slide. Again, this is an example from a pharmacy, intervenient medication component batch, and again, convert process in June 24. And that led to release with this example of angiotensin 2 and other dexmedetomidine, reduce cost, reduce on demand. Next slide. This is on demand dispensing. This goes to show by implementing, it reduced the amount of being drug wasted and all this stuff. Now, remember, drug wastage are not licensed. Somebody's paying for those drugs. The hospital patient, somebody's paying. It's not, nothing is free in life. So somebody has to store, somebody has to measure, somebody has to pack, somebody has to deliver, somebody has to measure. If it is expired, somebody has to take a load and waste it also. So it's not only environmental, it's somebody is doing that work, you're paying by that person, and they could be doing something better than what you do doing. So those are all things on this one is an example. Next slide. And beyond extended use, we use vasopressin and dexmedetomidine. In ICU, they were used, and we were able to make and change that. And you look at the amount less being wasted. Boom. Money saved. Administration responds to nothing better money saved. I'm telling you, with all due respect to my administrative colleagues, if I share them, I'm saving them millions of dollars. They want to partner with me. They want to do things. So they were happy with the environmental benefit, but showing this thing gets them engaged. Next slide. Team recycle. So we do a lot of recycling. This is just our team volunteering with this organization, which our hospital system recycle all the state-of-the-art equipment, and that goes to 130 countries by this organization. So our team volunteered and worked there. That is our, major critical care awareness. So this is what to share with that. So I just want to share with you. This is, again, keep on doing, keep on building. Next slide. So what have we done so far in some hospital system? Devices, 109,000 devices collected, which have been thrown otherwise. Waste diverted, 19,000 pounds, and CO2 emission, 127 metric ton was avoided. Just a snapshot, small. So what? This is all. Look at these people are excited. They want to do it. No, but everybody's smiling. They're happy about it because there's less work for them. Next slide. So more than $2 million saved. Pounds diverted from landfill, 24,000 pounds diverted in 2024 compared to 2021 or 21,000. So financial dividend, less workload, green dividend. Green is the color of US dollar, green money. So administration loves everybody, they empower, they support, and we are making an impact. And people are so happy and excited about it. Just gives you a show. Next slide. So this is some example of reprocessing highlights. Look at pulse oximetry. Look at 200,000 devices selected, renewal, and what we work with the company, which devices, pulse ox, blood pressure cuffs, and others. We do it. They fix it and they make it almost brand new, and they give it to us at a 1/10 the price. That means instead of buying new, we get the same thing and very safe for patient, all quality FDA approval wise. So less going thrown out and everything. This is an example of flushes. So flushes in every time you give a medication, nurses flush to in the IV tubing. So we looked at that, what is happening in our hospital system. So they looked at in one campus alone, they were using 700,000 flushes. In our hospital system, we realized we use 7 million flushes. Their houses said, we got to do something different ICU. They were started to, we need to throw all those flushes. They've diverted from landfill, and just in a few months alone, they diverted 1,600 pounds diverted. and not going through invoice, and they save a lot of money wise. Again, this is giving impact. Crash card revamp, how many things can be stored? Can we store less? Again, point. We're giving you all these examples. Real. Next slide. So labs, oh my God, we looked quantify the labs. We realized we are ordering billions of labs. This is from 5 ICUs. And we said, what's going crazy with magnesium and phosphorus? What is this attachment? Team are ordering crazy number of magnets, so we're changing that. Radiology volumes, this is left with the footprint of having an MRI versus a CAT scan or X-ray ultrasound. Look at the impact. We looked at how many we're doing, and we're changing some of those things because we have a huge opportunity. Our virtual ICU will on 2020. With the virtual ICU, less transport, less people coming in, less driving, more centralized. It has a direct impact on green ICU impact. Next slide. So with all of this, we said we can't do this alone. We created the first collaborative in the US. These are some of the key institutions, mainly in Texas, Memorial Hermann, Texas Children's Hospital, number one hospital in the country for children, Baylor College of Medicine, Cleveland Clinic, Central. Well, we got everybody together to kind of, well, hey, let's share together, let's learn together, let's make it together. We have created the collaborative. We also created a joint statement which people sign as individual, not on behalf of the hospital, and that we want to do something different. So this is ever increasing number of people who are joining us and get the word out. And lastly, this is our Green ICU conference, the first in the US and probably the first in most of the countries, which is dedicated the whole day on Green ICU Initiative, is on September 17. It is really, it's going to be mainly virtual, some in person because we minimize. We welcome you. There's a QR code. You can register. We'll keep updated. I highly encourage you because we all have to learn together. We ought to make a difference together. Next slide. So everybody needs a motivation to do something. All of us, that's important. Why do I do things? So why did I want to kind of do? Again, this is jumping on the plane. So my daughter loves to jump out of the plane. So she kept on pushing me, Dad, you got to jump. You got to do fly skydiving. So I was, no. So I finally took her plane. So I jumped in New Zealand. So this is, look at her expression, happy and smiling, and me stressed out. Oh my God, what am I doing? So we all need a motivation. So I'm doing this for my children and my children's children. And I think that's one of the main drivers. And again, patience and wise. So next slide. Green ICU, come in action, come join us. Be part, we're a big community. Think big, start small. Don't think to change the world in one day. Think big, start small, do small things. Build unity, build trust, and at the end, hope differently. We all can do it. Our forefathers did it, we all did it. So with that, thank you so much for allowing me to speak. And I think what Dr. Mesh mentioned, there'll be question and answer session. I'm happy to answer that. But again, Dr. Mesh, thank you so much. And now you'll get to hear the star of the show, Dr. Ready to speak. Thank you so much.
Thank you, sir.
Thank you, sir. It was an excellent presentation. And like how Green ICU Initiative was started in your ICU as a Green ICU team involved in the quality and the infection control nurse, and how it spreads all over the US. And it was a fabulous journey what we went through. And how the plastic affects each one of us. Thanks for that. Next, we'll move on to our next session to know the Indian perspective of this by Dr. Yash. Over to you, sir.
Thank you, Dr. Ramesh. Faisal sir has done my job easy and he is a stalwart. I am just a tadpole in front of him for this concept, and otherwise also he's such a senior to us. And it was lovely hearing to you, sir. You have already set the tone. So I will cover some of the philosophical aspects which are left and what we are learning and how are we starting. So the concept about green ICU, no conflict of interest, and most of my viewpoints are personal but scientific. We all understand green is not just a color, especially for us in this part of the world. Green is an emotion. Green represents life, nature, growth, balance, and peace. So green evokes a kind of calmness, optimism, and more importantly, freshness. So the concept of green ICU probably dwells on all these concepts. Sir has already elaborated on the basis of this green ICU concepts and what is the need. I'll still briefly touch upon the scenario worldwide. What are we doing, what our society, Indian Society of Critical Care Medicine, is doing, and what we should do. As already emphasized, the environment is no one's property to destroy, it's everybody's property to protect. But somehow in the name of development, in the name of commerce. We have forgotten this, and our kids are going to suffer, and we have already started suffering because of the climate change. Our past is our future. This is why most of the people live their future based on the past. They cannot break from it. But we have to break from old habits, especially the habits which are not fruitful, which are harmful for ourselves or for our society. So we need to have a break with the past. Most of the development, even healthcare, has not focused on the nature, and we were probably crossing roads with the nature and doing more harm to the nature and to the humanity in the larger picture. So green growth is the solutions. We have learned a lot from the history, and we should continue learning from the history. All the areas of policy are commonly justified by some reference to history. However, not that history is useless for policy, especially the medical policy, what we think, but if we carefully learn from our mistakes, we can indeed provide valuable orientation. And some countries are much ahead of us. Some countries have respected nature, and we can see how they look like and how we look like as of today. We wish the possibility of global sustainable golden age. This is a big wish, obviously. Environmental threats are no more a threat. We are suffering, they are causing morbidity, mortality worldwide. But these threats are opportunities, and they combine smart green growth with full global development. We should always remember that sustainable development is one of the greatest, if not greatest, global challenges of the 21st century. As already mentioned, healthcare sector is one of the keys to sustainable development. Although healthcare is not directly related to many of the goals, but only to the single goal or ensuring goal three, ensuring a healthy life. But indirectly,
Sorry for interrupting, sir. Can you
yeah,
be a bit loud, sir?
okay, just a second. Is it better now?
Yeah.
Okay. So the sector itself, the healthcare sector sorry, aims to protect health, but paradoxically, at the same time, it is the major emitter of environmental pollutants and have a negative impact on health itself. And the impact on humanity and the patient health is not only through the environmental pollutants. In hospital also there are a lot of pollutants in forms of aerosols, in form of room fresheners, in forms of various chemicals, which we are exposed as healthcare provider day in and out, and our patients are also exposed. What I saw, whenever we talk about some foul smell in the ICU or in the corridors, there will be some housekeeping and health spray. They will not look at the root cause. So we should look at the root cause so we can stop doing all these things which can harm our environment. Sustainability has become a key priority of healthcare organizations, and leadership in this area is essential at all levels. Climate change, which we are seeing for years now, is a symptom of severe relationship with nature. And we have to rekindle this relationship with the nature. If we do not respect nature, nature will not respect humanity, and it is already happening now. The climate emergency is a health emergency. And in the gap of COVID or malaria or dengue or cancer, we cannot forget climate emergency. This is the biggest emergency which is threatening all of us. The health sector, as already mentioned, accounts for almost 5% of global carbon emissions, variable worldwide, but this is the average. Cost of energy is also a real economic concern, even in healthcare organizations. Green ICUs. Green ICU basically stands for Greater Environmental Sustainability in Intensive Care Units. Care without carbon should be our mission. Each patient interaction, green ICU should be there in back of our mind. While I'm extubating the patient, I always think, if I surpass a T-piece trial, will it be okay? Can I give the spontaneous breathing trial patient being on ventilator? Can I use less number of suction catheters? So whatever you do in your ICU or in your healthcare practice,
always have this green angle about your practices. We have to look at sustainability, maintaining quality while sufficing with ecological, economical, and social resources available. So, this context will obviously vary from place to place, but sustainability has to be there. We cannot forget sustainability. Your ecology, economic, and social concerns could be different, but bottom line of green ICU is sustainability, and we should not forget about sustainability. Climate change is the single biggest health threat facing humanity. Climate sensitive health risks are disproportionately felt by most vulnerable and disadvantaged. We sitting in this part of the globe, especially the northern India belt, going from Pakistan till the area of Assam, we are severely hit by heat waves, occasional droughts, and many other problems and floods at times. So we are already started suffering from climate change. So we need to get our house in order. Earth is our planet. We, we belong to Earth. We should not do any harm in whatever interaction with the individual patients, not only to the patient, but also to the healthy ecosystem. New research work streams should involve evaluating materials, designs, energy, waste management, and circular economy for improving the environment sustainability, which translates into rich dividends from the environment and the financial dividends. What do we mean by circular economy? I will give you an example of, say, a packaging of central line. It comes in big packages. We use some of it, we don't use many of the items. So these items which are not used could be transported back to the manufacturer. And this will generate some money for us also. The packaging, you see many of these devices, many of these drugs, they required cold chain, they required ice box to transport. All this could be reused and could be sent back to the manufacturer so that there is some circular economy also while we think about green ICU. Why are we talking about it again? This was a study from England Public Health about carbon footprint of acute care, how energy intensive is critical care. They calculated an average daily consumption of 15 kilowatt hours of electric energy per ICU patient, mostly for delivering care to the patients and monitoring their condition, which is similar to that of an average four-person household. So you can understand how big is the number and why we are bothered. Again, this is published from Anesthesia Intensive Care. This was an audit of potentially recyclable waste from anesthetist practice. They did an audit of recyclable waste in a 10-bed Australian ICU. The total waste for the week was 540 kilograms, of which 60% could be recycled with appropriate processes, safeguard, education, or training. Yes, everything takes an effort. It takes a sincere effort. But if you put the right effort, you will have rich dividends. So we should live green, love green, be green. We are just mankind. Without the earth, we are nothing. And in the name of development, in the name of healthcare development, in the name of infrastructure development, we have already done much harm to Mother Earth. The most significant impact of ICU carbon reduction long term will be reducing the people's need for ICU through primary and secondary prevention of illness. This also has to be understood. If our carbon footprint is reducing from healthcare and globally, this is a sort of primary and secondary prevention of illness. Heat related injuries will be less, stroke will be less, CAD will be less, pollution related deaths will be less, interstitial lung disease because of the pollutants will be less. So there will be a lot of prevention and many other diseases will obviously come down. Also, we need to industrialize prevention. We have industrialized development, but we need to industrialize prevention also. Although our core work is centered at the bottom of the cliff, ICU staff should use our influence to advocate for preventative medicine, both with our colleagues, as Dr. Faisal has been doing worldwide, but also with our patients and with our communities. Whatever we do in the closed doors of our ICU should go to our hospitals, should go to our communities, it should go to people who matter most, to the administrators, to the politicians. They should have taste of this and they should understand why this is important. Dr. J.C. Farmer, the most efficacious critical care is the critical care intervention that a patient never needs. So this reduction in carbon footprint, bringing nature close to the humanity, will obviously reduce some diseases which are related to climate change. Whenever we talk about green ICU and sustainability, social justice and equity must be kept central throughout climate mitigation and adaptation processes. We understand some countries are suffering much more because of the evil deeds of other countries, but we also understand this world is a global village. So whatever we do influences other countries and other people also. The sustainability toolkit for ICU should collect ideas and actions we can do at our place, and we should probably steal shamelessly. We should not feel ashamed that Dr. Ramesh is doing some intervention. Shall I ask him? We should steal that idea shamelessly till the time it is benefiting our society. Every action, small or big, matters, and we understand in the ICU practice there is no big definitive change which can change the outcome of the patient, but multiple small steps taken in the right direction matters most. Similarly, in the fight for climate change, every small action matters. So start with baby steps. Going green doesn't start with doing green X. It starts with a shift in consciousness. So we should have this consciousness about saving our planet for ourselves and for the generations to come. Less is more. If we start practicing this all the time for all the interventions we do in our ICU, our carbon footprint can come down by 30 to 40% at least. We are a private hospital. Whenever we do an intervention, we obviously have to think about the financial status. Will the patient be able to afford? And we did a small audit in our ICU and we saw patients who were marginalized economically, the usage of various plastics, might be masks, might be gloves, might be syringes, was less. So we have this in our conscious that, okay, this patient we have to bring down the cost. It is worth pointing out that less is more is not a lazy approach. It is a well-researched and carefully thought out strategy aimed at getting rid of the therapies that do not improve clinical outcomes. Central line being one of the major habit we need to change. Many of the patients can do well without a central line, and we have to be very judicious which patient should get a central line, because central line is not that plastic alone. There is a lot of carbon footprint, the dressing, the chlorhexidine, the gloves, the mask. So a lot of things are involved. So less is more. Antibiotics, less invasive, less interventions, less on low evidence therapy, not too intensive, but we should not be overzealous. We should be doing enough. Less is more should not become a habit. We have to draw a balance. We should get rid of redundant practices and we have to look at effect versus benefit. This could be a beginner's guide. Already, sir has well in detail, and I am nobody in front of him to tell you more about it. Repurpose, reduce, rethink. Whenever you do an intervention, rethink. Should I be doing this? Can I do with a less of consumable? Can I reuse this mask? Can I keep this mask for this patient? What is my policy of reusing various equipment? What is my CSSD policy? Discuss with your infection control officer, discuss with your administrator, recycle the waste, repair whatever is repairable. So you need to have a policy which suits you best. Another major challenge is infection control. Most of these practices, we are afraid about infection control issues and we seldom implement this because we get a little scared about the infection control consequences. But we have to discuss, there is a lot of evidence about reuse. So there is a reuse policy in every hospital. So we should be following that policy and using it judiciously. Ventilator circuits, closed suction, we should be not changing it too frequently. So you should have a very, very judicious approach. Avoid daily wrong. You have to consider the green impact of your practices, ethics, futility. A patient who is in end of life phase, palliative phase, you should be minimalistic. You should just keep the patient comfortable. But most of the ICUs, the antibiotics are on, the ventilator is on. So we have to have a very, very clear vision about it. How to get started? We should have a green team. The most important thing in any ICU is the ICU team. ICU team shares the goal, they share the vision, we have mutual respect for each other, mutual respect for every advice. Most often, getting a green team started is a grassroots movement with a bottom-up strategy driven by champions. The nurses are best champions most of the times, or a young intensivist. All the team members should be counted in. Leadership support from the ISO director, from the administrator is required. At times, we will require some structural change. Please be free to involve our administrator. Early wins here are helpful. Starting a green team can spread and sustain our initiatives. We can reduce or avoid low value care. What has happened in last 15-20 years, especially in this part of the country, a lot of low value care has creeped into our practices. If we shun off this low value care, a lot of that would translate into the carbon emissions. Early goals may be specific, like you want to reduce gloves, you want to reduce the electricity usage in your ICU, you want to reduce the shoe cover usage. We stopped using shoe cover usage except for the immunocompromised. We shared the evidence with our colleagues, with the infection control officers, so we could bring this change. Early wins here are helpful. Goal for small changes, measure those changes, and share those changes among your teams. There are generally 4 stages which are described for any team approach. Form a good team, a motivated team, and keep them motivated. Storming, brainstorming, make the habits normal, norming, and then start performing. Obviously, a multi-professional team, they can be cash releasing to the administrators, there could be awards to the champions, and you have to measure your success based on smart tools. Reduction of gloves, everyone will be happy, patient will be happy, administrator will be happy. The most common reason for conflict in the bills in Indian ICUs today is the number of gloves. Single day, many ICUs would use 3 to 4 boxes of gloves, and when the bill comes to the patient, they are ready to take a fight. We have to be innovative. We have to give realistic, real world solutions which are relevant to our practice from the sustainability lens. We have to develop our practices to be sustainable. To what extent can our practice be sustainable? To varying degrees, but start somewhere. And to what degree it will benefit the patient and the nature, probably much more than we think. There could be deliberate clinical inertia in the art of doing nothing, but we have to overcome this inertia. Don't just do something, stand there and think. We have to probably start somewhere. And we are not talking about the Zen intensivist movement, which aims to create more clinicians and ICU units with a pragmatic patient-centered focus. And in this Zen intensivist movement, probably green ICU concept should be hammered into. People, we have to think, we have to train people, we have to train people at all levels. Purchase, pharmacy, supply chain. Pharmaceuticals are a high carbon hotspot, not only because of the drug and the vial, but because of the packaging and the supply chain also. Pharmacists can help reduce waste. We actually did a program for few of the pharmaceutical companies and they were happy to reduce on the packing, using a multi-dose vial rather than a single-use device like for enoxaparin, like for heparin. Dietitians should be called in, switching to enteral nutrition as early as possible. Plant-based proteins, fats, carbohydrates as part of oral nutrition. Power. Energy saved is energy produced. We were hammered during our childhood days, switch off the lights at home, why this light is on. So this has to be hammered. The new generation has probably forgotten everything. ISO is the predominant greenhouse gas emissions from HVAC. So areas which are not in use, probably you can switch off. You cohort your patients in one place. Suppose you have 3 ICUs and patients could be managed in two, close one unit and save on energy. Now we are talking about biophilic ICU, very close to nature, plants around the patients, but you have to look at the infection control aspects. Also, sunlight coming to the ICU, a family suite nearby. So we have to think differently. If we bring the patient close to the nature, the outcome also improves. That is why many patients go and recuperate much faster at their homes. Go green, go lean. Green ICU should serve as the foundation for harmonious development of all the things. The presence of living plants and animals, such as melodious birds, fragrant flowers around the ICU patients, they have a beautiful, spontaneous experience with the beauty of nature. And this can probably, this is a photo from a Spanish ICU during the COVID time, where they took the patient to the beach. So we need to open the ICU doors. We have nothing to hide, and we should be feeling proud of how we care. And biophilic ICU is again another such concept. To cure sometimes, to relieve often, to comfort always. So the green model should also be based on this. We should always have the green angle, the green consciousness in our mind whenever we take care of our patient, acute care or ICU or a palliative care patient. So a lot has been happening now. This is a first green hospital, totally green hospital, which opened in Istanbul in September 2022. It was designed to be enhancing patient well-being by utilizing natural resources in an efficient, environmental friendly manner. And something hasn't been happening in India also. There are NGOs which are looking at green hospitals. There are two green hospitals in Himachal Pradesh. There is one being built in Uttar Pradesh. So the ball has started rolling. We should be thinking about biophilic ICU. We have to merge nature and healing. Leadership in energy and environmental design. So this LEED certification initially was not for hospitals for some time in India, say 14, 15 years back. But now the newer buildings, they are getting this LEED certificate while they bring up the building and then gradually getting certified again and again. This is about air quality, waste reduction, energy efficiency, water efficiency. Effluent treatment plant is must for even smaller hospitals now. The government, especially the UP government, they are supporting hospitals to utilize solar panels. NABH also has started thinking about, NABH is like JCI for India, National Accreditation Board for Hospitals. They are also thinking about sustainability now, and there are some parameters about sustainability. Energy efficiently lighting. So this LEED certificate is now happening in many of the hospitals. Turn off lights, close doors. Turn off lights, obviously this was a campaign from NHS. Turn off lights, or electricity usage will come down. Close the doors, your air conditioning requirement will come down. So we need to do every small bit of it. Procurement, again, a big challenge. Purchasing is a large component of our footprint. Reusable option, reprocessed devices. We have to have product stewardship. Is there a center line which is available without that paraphernalia which we rarely utilize? Use that. Circular economy, price tag. Put the cost boldly on every product. If you put the cost boldly on every product, the nurse, the clinician, the physiotherapist, they will be aware. And we have to share our resources. Sharing is caring. We have to share our resources. We are thinking about having a common ICU pool for the areas of need. Suppose there is a flood in some area, we have a common ICU pool of equipment and drugs, we can transport that. Probably this should become a global phenomena so that we share our resources. Already people are doing it. Processes, policies, and procedures. How much do patients value environmental sustainability intensive care? So patient and their family should also be taught this. How does the carbon footprint of reusable PPE gown compare to disposable PPE gowns? Our ICUs, we do not use shoe cover. We do not use a gown for patient and family unless it is an immunocompromised patient. How much climate change induced illness is presenting to ICU? This is again a big thing to look into, and the number of climate change induced illnesses is rising, and we see an epidemic of health related illnesses. It could be heat stroke, it could be heat exhaustion. In the coming months, we see a lot of carbon monoxide poisoning because of the gas geysers. So there's a lot of climate change induced illness which is presenting too. There are chronic impacts of pesticides which are circulating in our water resources. We need to have diagnostic stewardship, what to do, what radiology is required. We should be using digital resources. No need to print your X-ray films. Just look at it digitally on your mobile or in the hospital system. Our processes, policies, and procedures have to be refined. Pre-made clinical procedure packs do not have this industrially packaged clinical packs. We need to educate and train telemedicine. Telemedicine is again decreasing our carbon footprint. Health related travel is 5% of travel in England. So if we reduce this with telemedicine, lot of carbon footprint will be reduced. This health related travel could be for the patient, it could be for the patient family, it could be for the clinician. So suppose the patient is admitted in an ICU here. The relatives will come from a city which is 500 kilometers, some relative will come from UK. So this health related travel could be reduced if we allow telecommunication with the family and we do it. Plastic and pollution waste, already a lot has been discussed. NABH is again very serious about it. They look at your biomedical waste disposable policies, how much you emit, how much you supply to the third party for recycling. Better segregation of waste streams is must in all the hospitals now. Cost awareness about plastics is again very important. You can change your staff room into more sustainable area. Do not use disposable glasses, disposable plates. Keep a jug, keep a steel jug, keep a glass jug, keep a brass jug, and utilize or keep a steel bottle for yourself. I carry a water bottle daily. So we need to be very cautious about it. Take My Hands, this is again another campaign, is a social enterprise that connects those that have with those that need it. You need a resource, we are resource rich, we share it with you. Again, another important concept, waste is only waste if we waste it. Recycle it all, no matter how small. Paper, cardboard, you can recycle it, you can turn it into manure. Okay, another good example I'd like to give you is Indore, which is the cleanest city, and there is a certification which goes on year after year for this. They have made this biocompost pits compulsory in hospitals, in hotels, and they have started doing it. All the commercial establishments, they have to have a biocompost pit. Do a waste audit in your ICU, reduce your paper use, do not print if you don't require it, repurpose your shelf. Another important concept is e-waste is the fastest growing waste stream, although we talk about going digital, telemedicine, tele-ICU, but this should also be kept in mind that e-waste is the fastest growing waste stream. So we need to refuse what we do not need, refuse what you do not need, reduce what you do need, reuse what you consume, recycle what you cannot, refuse, reduce, reuse, and rot, compose the rest. So we have to be very, very sensitive and recycle the waste. Waste is only waste if we waste it. There's no such thing as throwing away. When we throw anything away, it must go somewhere and it stays on the planet. And we saw in that study how microplastics and the nanoparticles are coming into our blood circulation. Any waste stream in our society can be turned into a revenue stream. It's turning the lemons in our society into lemonade. So we have to think about how to dispose of biomedical waste rightly. Obviously, the infection control concerns are very, very serious. The urge to overprescribe, the clinicians nowadays, there is pill for every ill. They are so frenzy about prescriptions. ICU is a significant pharmaceutical consumer, so we need to be having self-reliance and environmental stewardship whenever we prescribe. Do not over-prescribe. We should have a reduced mindset, less is more. If we have this less is more plan in our mind, a lot of our carbon footprint will come down. Reduce, review the treatment chart daily. Does my patient require an pantoprazole injection or a tablet is good enough? Does this patient require heparin from a single injection, or I can use a multi-dose pack? Bottles, share drugs with patients. So we should be taking care of the pharmaceutical waste very, very seriously. Don't open stuff until you need it. Create a healing environment. Reduce noise, reduce lights, reduce toxic chemicals. We have to have a fragrance-free hospital. I will again like to quote an example. There was a patient of COPD with us. Patient was with us with an acute exacerbation. Patient was doing well. I was thinking to shift the patient out of the ICU to the room. And suddenly I was sitting in my chamber. I get a call from my resident. Oh, that patient is again having respiratory distress. I could not point out. Then I realized there is some fragrance in the air. Then I could sense that somebody has sprayed. So the day we stopped using all sorts of fragrances in our ICU. The HVAC system again is very, very energy intense. Testing should be driven by clinical questions, not curiosity. Let's order something syndrome for pharmacy or to the lab or to the radiology has to die. We should not be overdoing. What is required should be done. The lightning shading system, the data processing system, clinical lab tests, everything have some carbon footprint, and we should be looking at all those aspects. Politics, taking personal and professional action. Medicine is a social science and politics, nothing but medicine at a larger scale. So medicine has the social consequences also, and you need to take the smaller lessons which we learn in our ICUs about the green impact to the community and to the larger for the larger good. People are the essential component in changing systems, so we should utilize our human resources. People power is good for advocacy, and intensivists are well heard in the hospitals, and many of us are leaders in our communities. So we need to probably advocate at various levels to best of our capacity, and we have to be a ladder of political activism. We always talk about global collaboration. We talk about one world, one health, open sourcing of ideas about green ICUs, democratization of knowledge, resource sharing, global alliances, data platforms, networking, platform trials. Research also involves a lot of greenhouse emissions. So platform trials and open source research probably can reduce the footprint of clinical research. Dr. Faisal already mentioned how Australia is way ahead of most of the countries. We need to learn a lot from Australia. This is about green certificate for OT. So this has already started happening. And this news clip is from 2016 about the green OT certifications. We published this ISCCM guidelines for environmentally sustainable critical care. The theme was environmental safety and energy efficiency in intensive care. We had a quiz campaign also for this. And our theme for the this year national conference was also sustainable technology in green ICU. So we have started thinking we need to put a lot of sincere effort into it so that we do a lot of goodwill for our patients, for our healthcare organizations, and for the community and planet Earth at large. Time is pressing, and critical care medicine must participate in the race to zero emission healthcare systems. We need to walk the talk. We should not be adopting this green sham. Sadly, there is a lot of green sham in many of the interventions. Most of it is for just a sham. ICU is an environmental hotspot, gowns, gloves, CRRT. You should be very, very cautious while to use CRRT. CRRT is again being pushed in a big way, or your patient could do well with SLED or hemodialysis because CRT has a bigger footprint. While you design your new ICUs, keep these green ICU things in your mind and you maintain your old ICUs, modify them for the greener outlook. Thank you. At the last, I like to quote Dr. Margaret, who was the director of WHO. A ruined planet cannot sustain human lives in good health. A healthy planet and healthy people are two sides of the same coin. Thank you.
Thank you, sir. It was an excellent and elaborative presentation on Green ICU and in the Indian perspective. And you have touched upon less is more, biophilic ICU, green hospitals, LEED certification, and all. So coming back to our questions, I think but Faisal sir, what are the bedside tips you want to give for our nurses at the bedside who can reduce the burden of carbon footprints?
So I think one thing Dr. Very mentioned is that the COVID changed a lot of stuff. With everybody was using a lot of stuff, especially we got paranoid with gloves, gowns, and everything. I think that fundamentally has to kind of think. And what we have to kind of think is, do we need to always wear gloves? And actually, in fact, shown that if you don't wash your hands and use gloves, you have much more chance to cause infection was washing hand and doing it.
That's
I think that's something because that's one aspect, right? The second aspect is really that what we realized in our ICU also that we went to ICU with the nurses prepared the room with the next patient coming in. And we realized that they prepared a lot more stuff in the room than it was needed. And the patient in our hospital and policy was that if the patient in the room and something we did not get utilized was not reused for the second patient. That means that was not properly utilized. Or if the patient who had some isolation thing, then everything got wasted. Well, why do we need to put everything in the room? Just use what you need to do. So actually they did that work and they was talking about 60 elements, they dropped down to 40 points. So it's not that we're not giving them, they're just across the hall in a storage area. So I'm just giving you simple basic steps. Another thing they're working on is sleep hygiene. That means why do we need all the lights on? People want to sleep, you keep all the lights on. So we feel, as Dr. Very mentioned, we're trying to do the simple steps to get engaged them, and instead of changing them drastically. And I think what that does, it empowers, they feel they can do it, and then they're more open to do bigger steps.
yeah. Yes, sir. Is there any way how we can calculate the carbon footprints in our ISO each and every day?
It's the challenge. Doctor, very
No,
sorry.
sir, please. From your
No,
side.
please go ahead.
Yeah. So we need to have a conscious effort. First thing is this. Do I want to reduce my carbon footprint? And in the process of reducing carbon footprint, you reduce a lot of cost to the patient. And we understand in this part of the world, most of the patients are paying from their pockets. So we need to reduce cost. It could be the number of tests you order. If a new patient comes to your ICU, to your hospital, you can check on the report. This test was done yesterday only. Do I suspect anything new? So diagnostics also take a lot of our money and it generates a lot of carbon footprints, especially the radiology. We should not be repeating a CT scan on X-ray almost on a daily basis. Do not print the films. Have this diagnostic stewardship in your mind, whatever you do. Doing a CBC daily, doing a chest X-ray after a central line or after an intubation, we have an ultrasound in our hands. Probably we need to break off with those old habits because they are energy intense. Second thing is plastics. Plastics are the major greenhouse emission, and they have a very deleterious effects on the nature. So we need to reduce plastic in any form in our ICU, gloves, cap, mask, gowns, shoe covers, all this has to be reduced. And we have to start somewhere. Take baby steps, and probably it's a long journey.
One thing I'll add to that is, Dr. Ray mentioned it, it's paramount to communicate to the healthcare team and the patient that this is not a goal to cut cost. Because if they feel that are you saving money on and compromising my health, they will not, they will be very worried. So it's very paramount. The goal should not be to cut costs. The goal should be exactly what Dr. Ray mentioned. Do what the patient is clinically needed, not to feel yourself comfortable.
Faisal sir, are there any challenges or the barriers you faced during your journey of Green ICU?
You know, first of all, is again the challenge is awareness and engagement. I mean, we are still working on awareness. We're still talking about engagement. We're still trying to work in our own is to kind of to really have a good understanding. So what we've done is so far is we've done one internal system-wide survey, and we actually with SC Societal Care Medicine Support, we've done a nationwide survey. So we're analyzing the survey. We're hopefully we'll publish it pretty soon, both of them to really, because the first thing is the biggest challenge is if people don't know or they don't care or they don't feel it's important, they're not going to do it. You can't go to the second step with the first step. The second challenge is they say, well, the hospital administrators are not going to support us because they say, well, I'm not going to buy a green bulb. I'm not going to buy a new AC because it is thing wise. So those are some of the things which would be. So those are some of the challenges which we face and everybody else face. That's why we have to go in a smart strategy. Just like if you could see, we shaved a lot of bonds saved and financial saved. We bring a lot of financial input up front. What that does, it disarms the naysayer because they can't say no to when they're saving money. So we say we're providing the same high quality care, saving a lot of money, and by the way, it has a greenhouse impact. So we articulate our discussion in a slightly different way because remember, I'm in Texas, so this is all capital of the world. So we have to kind of formulate and want to work with the challenges. And so far, I think we're making headway.
So major, I think the fear of infection, use of more number of gloves, more number of gowns. That's what I think it is a major barrier. I think we have to break that and then come out of that. Probably in many issues they are not using the shoe covers. Now I think we have to make it a protocol not to use that. And unnecessary usage of gowns as Yeshua was telling. I think that is sir. Any companies in India you come across who will recycle the items like breathing circuits or infusion sets and all?
Not for breathing circuits, but for the machines like infusion pump or an outdated ventilator. There are a lot of companies.
Yeah.
I'm forgetting the name right now, which recycles. And in fact, you can get ventilators from UK and US, which are refurbished ventilators. Refurbished motorized beds are now available at a lower cost, obviously. So things are happening. Ventilator circuits and see respiratory equipment. I'm a little scared about reusing and recycling, and the infection control team has to be buy-in in if we think about it. Ventilator circuits are mostly heavily contaminated, and plastic getting recycled remains a concern. The infection control concern remains more so in the respiratory equipment and consumables. The rest of the things which we are little comfortable in using.
So I
Dr.
will add to
Faisal,
that.
sir, can I? Yeah, sorry.
So I'll add to that is that certain challenges we all face is because of regulatory requirement, legal requirement from the state or the country,
Yeah.
and that binds some of the manufacturers. So it is what we think we should do versus what the regulatory requirements say that you have to do. That is a little bit more uphill battle to kind of do that because we talked about certain company. They say, well, we would love to do that, but we're bound by law to do this way. So I think what you mentioned is, yes, it makes scientific sense, but the science, I would say the evidence is building up slowly, because until the regulatory environment also don't give a little bit more flexibility, then our and your hands are slightly tied. So it's, as I said, it's a journey. And I think people are now looking at it. Do we need to do that? And what evidence was that based on? And you'll be amazed, the evidence was not a very high quality evidence.
In the hospitals, ICU especially, which is having a large windows, which so that the natural light will be used instead of the lights what we use. So that is again, I think it should come in the planning of the ICU before only. So I think any other things you want to share, sir?
So we
Every
need to
steps
hammer
count.
this into our administrators and the hospital designers. The hospital designing has become not more scientific in last 15, 20 years, but our opinion should also matter. While we design a new ICU, obviously the intensivists, we know something more than them about the ICU design at least. So every opinion matters, although the hospital designing has become a lot more professional. The ICU designs are much better than what they were 15, 20 years back. But our opinion should also matter. We in fact bought a guidelines about ICU structure a few years back, ICU structure and designing, and we mentioned on most of these things. Yeah. And they're dedicated people, and they're some of them are very, very knowledgeable. Actually, if you interact with them, these hospital designers, there is a national building council who have a dedicated healthcare wing who brings up many of the hospitals. The Safdarjung building in Delhi was bought by them, and it's a very green hospital, although the numbers of patients are too big, but it's a green building.
You're telling something, sir? Faisal, sir?
No, I was just saying, I would say exactly. I think that people are much more knowledgeable. And what I tell is that, the younger faculty, intensivists, nurses are more cognizant and much more aware. And I think they are more proactive than we were. I'm learning now, a few years ago. For them, this is real and happening now. So I think I have much more faith and hope from them. But I do feel that we still have to do our part. And and I think they will do a much better job than what I did.
Yeah. I think to conclude, beyond our hands, keeping aside the beyond our hands, the ICU leadership is very important, keeping in concern of the green ICU and all, and involving the team, like young intensivists and the clinical pharmacists who can reduce the number of drugs, and the nurses who can be more educated, and then make them to use less number of gloves, less number of avoidable items and all. So I think this is the way forward, and we can start with the small steps, and then we can expand it over the country with the guidelines and all. So with this, we came to the end of this session. I would like to thank both of our panelists who has enlightened us on green ICU strategies and on how to start with, and then how to build up a team. And I would also like to thank our delegates who was there till the end, and definitely our founder and chairman, Dr. Guru and Reddy, who was behind these sessions, and our IT team who was communicating with the panelists, and then our delegates and all. Thank you, sir.
Thank you.
Dr.
Thank you.
Ramesh.
Take care. It's a
Thank you,
pleasure.
sir. Dr. Faisal, sir. Very nice interacting with you, sir.
You get to know Vulcan at more. Okay, thank you, very.
Bye-bye. Have a good day. Have a good day, Dr. Ramesh. Bye-bye.
Thank you, sir.
Have a good day, Dr. Masud. Thank you.
Yeah, sir.
Thank you, sir.